Much. So I'm delighted to be presenting here this morning on this in this interesting session, and going to talk a little bit about the epidemiology of weaning. These are my conflicts of interest. I don't have any conflicts in relation to the subject of the talk. In terms of background, weaning from invasive ventilation is something that's common to all intubated patients. Sometimes it's quite straightforward, but other times it can be quite complex and prolonged. And, of course, sometimes it fails. And up to 40% of the time that people are on invasive ventilation, they're in the weaning phase. So it's a significant portion of time. We know that duration of mechanical ventilation is clearly associated with poor outcomes. And that weaning failure is highly associated with mortality. To make it more complicated, we have, there's a lot of confusion around terminology when it comes to weaning, and we don't really have any agreed definition of weaning. This is from the ERS ESICM task force back in 2007, and so we're sort of awaiting new guidelines. And we all know, of course, that there are numerous complications from prolonged invasive ventilation, from infection, delirium, muscle weakness, and so forth. And so limiting the duration of mechanical ventilation is a key clinical priority, and an area we need to research more. And when we consider the amount of time people spend weaning, that's clearly a part that we could potentially shorten. However, we also know if we get it wrong, so if we extubate and patients fail, that when they are re-intubated, that group has a significantly higher mortality risk. And this is a number of different studies carried out over a 15-year period. And they all show in the red bars the re-intubated patients have a substantially higher mortality. And when we look at rates of re-intubation, they're fairly stable between 15 and 20% across these studies. So we have a significant failure rate, and these patients do more poorly. In terms of the recent studies, this is the WeanSafe study. I was fortunate to be involved in this along with Laurent Bouchard, Tai Pham, Leah Hunks and Giacomo Bellani. And in this study, we looked at patients who had at least 2 calendar days of invasive ventilation. So we wanted to pick a slightly higher risk group. We screened just over 10,000 patients. About 4,000 were excluded because they were either not ventilated for long enough or they were transferred to other units. And so we had a study population of almost 6,000 patients, 5,800. And so of that group, so these were all patients who had at least 2 days of invasive ventilation. So, not that long, really, in many respects. So about 2/3 were male, 1/3 female. Their age mean age was 61 years. They were, in terms of body mass index, they were just sort of on slightly overweight side on average. Pulmonary comorbidities were high. Diabetes was high. Cigarette smoking about 14%. And mobility issues were significant in the population. About nearly 70% were medical ICU patients. The 22% were surgical, and 9% were post-trauma. And in terms of the reason for why they were admitted, the chief reason was pulmonary, so respiratory failure. Second was sepsis, and the third was neurologic disorders. So in terms of our patient group of the almost 6,000 patients, at least 77% had at least one separation attempt. So that means there was one attempt made to reduce the respiratory support. It could be anything from an extubation to reducing pressure support to getting them to see if they were ready to wean. And of that group then, most of these patients weaned. So 65% of the total group did successfully wean from ventilation. And of the minority that did not wean, most of these patients died. So if we didn't get them off the ventilator, they either died or they were transferred to a specialist weaning unit. So in terms of the whole population, so this is just looking at the outcomes over time up to day 90. We follow them out to 90 days. And what you see is of the entire population, so these are people who have 2 days or more of invasive ventilation, 65% of them successfully weaned. So only just about 2/3 of that group weaned. 30% died, and 5% were transferred to other facilities during the time period. If we look at the group that entered the weaning phase, so the clinicians decided that they were well enough to have a separation attempt, the numbers are, as you'd expect, better. 84% of those successfully weaned, and mortality in that group was 12%. So what we wanted to look at then was the time course of weaning events in this population. So we start the graph at day 3 because that's when the patients entered the study after 2 days of ventilation. And what you see, the black line are those who died, and on top, the top line are those who had some sign of spontaneous breathing. So that could be anything from a mode that permits spontaneous breathing to a mismatch where they are clearly breathing over the ventilator. Almost all of those patients met weaning criteria, and we define the weaning criteria as follows. So an FiO2 of less than 0.5, a PEEP of less than 10. They had to be either on no vasopressors or low-dose vasopressors and no paralysing agents. So they were our criteria. We felt patients were eligible to be weaned at that point. And so that's and so then the blue line then is the first separation attempt. So what you see is there's a gap between the first separation attempt and being eligible or ready based on criteria to wean. So we wanted to try to understand that better and explore it. This is the group that did get into the weaning phase. So they did have at least one separation attempt. And you see again here, there's a delay, particularly in that first week. And so there's a significant gap there between being ready to wean and the clinicians first starting to wean the patients. Now, there are some good reasons for why that might be, but we wanted to understand them. And so then we classify these patients using the WIND criteria. So this is the criteria developed by Gaetan Bednou and colleagues in the French WIND study. So we have a number of groups. So the first group is that group that they either die or are transferred before they ever enter the weaning phase. So they're critical illness, they succumb. And the successful weaning short group then is they wean within the first 2 days of their first separation attempt. So the clinicians try to take them off the ventilator, and within 2 days they're off the ventilator. Or within a day, sorry, they're off the ventilator. And then days 2 to 7 is kind of intermediate. They successfully wean, but it's an intermediate wean. It's a little bit more complicated than the short wean. And then the third group is the group that are successfully weaned but need 7 or more days to wean off the ventilator. And then we have that group that die or transferred. They have entered the weaning phase, but they fail to wean in that group. So when we look at this in this table, so we've broken them down by these groups. So the short wean, the intermediate wean, and the prolonged wean, and then that group that failed. They died or were transferred before weaning success. So what you can see is age is around about 60. The people who failed were older. They were more likely to be medical ICU patients. And in terms of admission types, they were quite similar, but they had more comorbidities and they were more likely to be frail, the group that died or were transferred. And in terms of outcomes, as you might expect, there is a stepwise reduction in survival depending on the weaning group you're in. So you're almost 90% who wean quickly survive, and that drops down to only 19% in that group that fail. So it just tells you how critical weaning success is in terms of outcome for these patients. So what we wanted to look at then was in that group that were delayed in entering into that weaning phase, so that group that were in that gap, we wanted to look at that group. So they had a delay of at least 1 full day from being eligible to wean. And so we want to look at what the factors were that were associated. Now, some of these are not that surprising, like frailty. Trauma is there because of neurologic injury. Post-cardiac arrest, again, neurologic. So you see a strong predominance of neurologic. The use of paralysing agents is there as a factor in delayed weaning. And another modifiable factor is sedation. So we found that sedation was very strongly associated with delayed weaning. So this is at the time they're ready, they're just too sedated to enter. That's strongly associated. And when we looked at failed weaning, so these are people who did not wean successfully from mechanical ventilation, even though attempts were made to wean them, we saw similar groups again. So immunocompromised was here in the failed weaning group, but again, you see deep sedation was the most strongly associated. So 3.5 was the odds ratio for deep sedation at the time of being ready to commence weaning. So this is a potentially modifiable factor. So another key study that I want to discuss is a study led by one of our chairs, Dr. Karen Barnes, and this is the study that she led on weaning practices published last year in JAMA. And what they looked at, they looked at 2,500 adults who they enrolled and then followed up 1,868 in the study population. And what they found was that if you were directly extubated or you had a direct tracheostomy, your mortality was relatively low. And in the groups that underwent spontaneous breathing trials, so again an attempt to wean, if they were successful, mortality was significantly lower than if they failed their first weaning attempt, which again is an interesting insight. So getting that right seems to be important. One aspect of the study I wanted to focus on is just the geographic variations that were here. So Karen and her colleagues looked at based on the countries that had enrolled patients, and there are some interesting differences. So, for example, if you look at, say, United Kingdom or Australia, there's quite a low rate of screening for readiness for spontaneous breathing trials, whereas you look at North America, pretty much every patient, or 82% of patients, were screened daily for their readiness for an SBT. And similarly in terms of whether or not they had an SBT. So there's significant geographic variation. There's even variation, of course, of what we call an SBT. But there is significant variation in practice. Right? Another interesting insight from the data is who does the daily screening. So this is because we have different people doing this. So in the United Kingdom, and Ireland will be similar, this is done by intensivists, whereas and same in Australia, whereas in North America it's done predominantly by respiratory therapists. So we have different people doing them, we have different amounts, different approaches to daily screening, so significant diversity in practice. In terms of sedation, I include this because this is a common theme across both studies. People were sedated were at quite different levels of sedation as they, when they had SBTs or were extubated, and there was a clear trend to higher failure rates if you were more sedated. The SBT technique, so your type of SBT didn't seem to make a big difference, whether you had a pressure support, spontaneous breathing trial, or say a T-piece. But things like if you were sicker, if you were more sedated, or if your site didn't have a ventilation weaning protocol, they were all associated with failure of your first SBT. And in terms of ICU mortality, this was reasonably stable across the different areas, but it was higher, of course, if you failed your first SBT. So in terms of insights, again, successful weaning of patients from invasive mechanical ventilation is a critical step in their recovery. And a lot of patients who die in the intensive care unit die because they fail to come off the ventilator. So in those patients who are just 2 or more days ventilated, 77% enter the weaning process, and only 2/3 successfully wean. So if they're 2 days in the ICU and they're invasively ventilated, 1/3 of those patients will not wean in our current practices. There's a lot of variation in practice. Now, what's not clear is how strongly these variations are associated with outcome. Some of this is geographic. A lot of it is actually right down to hospital level variation. And delays in weaning, in getting started with the weaning, are associated with ultimate weaning failure. And we see that sedation seems to be a key potentially modifiable variable in all of this. So we really need to be thinking about getting our patients' sedation optimised as soon as possible once they're ready to wean. So in terms of future directions, I think we need to standardise terminology This is actually very difficult and really confounds research in this field. There is a task force looking at this, ESICM and ERS. We need to encourage wider SBT use. Now, what's not clear is how well that will improve outcomes, and that's something we do need to look at. And we need to focus on that group that are at risk for prolonged and failed weaning. I think we know quite a lot now about who that group is, and personalise the management to these people, and then focus our weaning trials on that patient group. And we need to look at long-term quality of life in this patient group. With that, I'll close. Thanks, Chair.
Thank you very much, John, for this nice presentation. Any question? Please go to the microphone. Yes, please. Present yourself and take the microphone. I don't know if you want one or you have one here.
Yes, I'm Dr. Aleb from Saudi Arabia. In your group, in your study, what happened to the re-intubated and what was the percentage of re-intubation?
So all of the patients in the study were intubated. They had to be 2 days on a ventilator, if I understand your question correctly. Yeah.
The re-intubation rate.
The re-intubation rate, sorry.
And where you put them again, in which group?
Yeah, so ultimately they were grouped by successful extubation, so they were categorized by their ultimate extubation. The re-intubation rate was around about 15%.
Quick question, John. So if you were designing a randomized controlled trial, how would you take variation in screening to identify people who are eligible for an SBT and sedation into consideration?
Yeah, that's a good question. One of the things that we, there was the reviewers when we were publishing found, came back on was that we didn't include sedation level in our readiness criteria, because if you do that, you can't then examine sedation as a factor, right? I think we need to focus on the groups that are, and the other, focus on the groups that are higher risk, and then, really standardise the terminology. So you've got to set really clear criteria for what an SBT is, because my SBT will be different to your SBT. And one of the things we found is centres that, and it's happened a lot, where we would look at their data and we'd say, oh, you did an SBT here, and they'd say, no, that's not an SBT. And we'd say, well, it looks very like an SBT. So we would have to standardise what we call an SBT and then really rigidly enforce that, so that, you literally, if they meet, these criteria, they get an SBT. And then you have a menu of what those SBTs will be, because of course all SBTs are not equal.
What I really liked about your study criteria, your eligibility criteria, is they were independent of extubation criteria, extubation readiness. So I think we also need to clearly separate liberation from the ventilator from liberation from the endotracheal tube.
Yes, yeah, that's true. And we haven't really looked yet at the extubation part, but we have been able to parse that data. We know we can look at that. Yeah.
Professor Maggioli.
Hello, thank you, John. Very nice as usual. Just a comment, and because looking at this data, the impression is is quite expected. Nothing has changed since many years. I could say probably the same 10 years ago. So, in your, you have a lot of data experience also since a long time. If you could identify one thing that probably now, today, is changing in this field, what is for you? This is the first one. And the second one is because you said that we have problem in standardized terminology, but also in standardized practice. And in that sense, maybe automation may help, at least in standardized practice, and probably also terminology. What do you think about this? This can be a good direction for the future?
So, to your first question, I agree. It's a little bit depressing that we're talking about weaning 20 years later and we haven't made a huge amount of progress. I think what the studies do, is they draw very clear attention to the burden, we're very focused on the acute phase of critical illness, and then when we get them onto pressure support, we think, oh, yeah, our work is largely done here. And that just is not true, right? I mean, most patients actually die in the weaning phase, or certainly a big chunk of patients die there. And so the aim of this is to focus people more back on that and start to design trials. I know people are doing trials. I know Dr. Burns is doing a trial, for example. And I think the trials need to focus on the higher risk group, because there's a lot of data around weaning that's done in people who are at low risk of weaning failure. And that data just doesn't advance the field, right? Because what you need is genuine uncertainty about whether or not you can get this patient extubated, and that's the patient that needs to be in the study. And I think now we can define that patient a lot better, right? To your second point, I think there is a role for automation. Yeah, I think there is a role for weaning modes, more sophisticated processes that would do some of this weaning, especially at night time when maybe the nurse-patient ratios are different and that kind of thing. So I would agree it'll have to be in tandem with good sedation policies. But yes.
Thank you very